Hello everyone and welcome to another VMR. My name is Shema and today, long time ago, no, I have the honor to discuss with Rabih CPS again. As you can see, I'm a bit excited again. I was so totally out of clinical reasoning and also speaking in English is some troubles, still some trouble, but as you all know, we're a nice crowd that can help me if I have some trouble finding words. And I'm so excited for the upcoming discussion. And I would ask, is there anyone who would like to present a case? If so, please raise your hand.
Well, hello everyone. I see Bia just joined us, and
hello.
Guys,
I'm having like a month that is like incredible. I've changed like 3 laptops.
Oh my gosh.
Yeah, no. Well, one of them was actually lent by a friend of mine, but yeah, so I've been installing Zoom like for at least 3 times now.
Oh no.
So yeah. I should be on the last one, hopefully, for years. But I don't
Fingers
want to say
crossed.
it out loud, otherwise. Yeah. Anyway, I hope you're all okay. And
Hello. How are you otherwise?
yeah, for the rest, okay. It's just this small issue.
It's not small. It's very annoying. We depend so much on our laptops. It's not small. It's like my third leg, you know?
Yeah, it's mine as well. And to be honest, I've lost some important data.
Yeah.
I was writing my cases and I've lost like the last 3 months of work because I'm stupid and I didn't synchronize it on the MATLAB drive. Yeah, but I'm stupid. But this it's always an opportunity to learn. And everybody out there, please upload stuff on other drives, or otherwise maybe lose your work, like months of work. Yeah.
Let me tell you a story, Bia. And on exactly May 11th, 2021, my entire life's work in medicine was hacked, deleted, and lost. All that I had worked, all those schemas, there were about 4,000 of them at that time. They were hacked, stolen, and just gone. And you know what happened to me? I got so emotional and so crazy that I accidentally crashed my car into a pole. I was so like, so the person, by the way, who did this probably had access to, like, figured it out from the YouTube videos and from the schema sharing on YouTube. So if you're listening, you owe me a car. But anyway, these things are so emotional because it's literally almost your baby, your work, your thesis. And so you're not stupid. You're a fully alive and functioning human being who is attached to some things that are a fundamental part of your life. And I'm so glad you have a laptop and so glad you have Zoom, because otherwise we probably wouldn't meet or connect in this way. And so you processing that difficulty is important, and I'm so glad that you're processing it better than crashing your car, unless you have some more news for us, which you haven't shared yet.
Well, I have a driving license, but I don't have a car.
Okay, there you go. Good.
Otherwise, I would.
Excellent.
Yeah.
Yes.
But yeah, I mean, your situation is even like bigger than mine.
Oh, you know, they're all.
But yeah.
They're all bad. They're all bad. But we're very glad to have you here. And yeah, I don't know if you know what I'm about to tell you, which is that a long time ago, about a year ago or so, a year and a half or so ago, the health of VMR was not good. People weren't joining as much. There wasn't much happening. And around that time, Shema became leader of VMR around that time. And she almost single-handedly did the whole code for VMR, from asystole, PA arrest, to a very healthy, completely like alive, normal full neurological recovery VMR. That's what Shema did, almost single-handedly. And then a whole generation of people followed, including Maddie, Yaz, Andrew. I'm just saying in order: Maddie, Yaz, Andrew,
Deborah, everybody.
And so what's happening today is incredibly special because Shema had to go and lay low for a while, studying for 3 full days of a very important exam. And today is making her return. So get ready for the heat, y'all. Shema's back. We're very, very excited. She's expressing a lot of discomfort about her English, which because she's been deep in German. So yeah, Shema, whatever words you speak, whatever language, they'll be wise. We're very excited to learn. And I'm not sure, Bia, are you still in a space where you want to present the okay?
Yeah,
All right.
yeah,
Okay. All right, let's do it. Let's
of
rock and
course.
roll.
So yeah, by the way, I can relate with Shima. Like this old Italian French is messing up with me as well. Anyway, so this is a case from my pediatrics rotation here in France. So we have a 10-year-old female with poor weight gain. She's been having poor appetite for 4 or 5 months as well.
Okay.
I think I'll stop there and then
Okay, seeing we're in pediatrics. I know Rabih loves pediatrics so much. So first of all, we have a very young girl with poor weight gain. So first of all, you can ask yourself a question: is there any systemic disease ongoing that can go in with any malabsorption? So especially going into epidemiology, like celiac disease, it's a disease that can be prevalent in children especially, and it's not that rare. So even if you eat so much, but seeing that she has poor appetite, the key question is there, we can also go into the more genetic direction, or is there something like, did anything happen, when she was born? Like, was she full term or not? Because as you know, or is there any kind of history with short bowel syndrome? Did she have, where sometimes children that were born with malrotation of the colon of the small bowel, that can also go in with short bowel syndrome or any kind of malabsorption? Then also thinking of any vascular thing, as you know, sometimes we had some amazing case about like something like SMA syndrome, this mesenteric artery syndrome due to compression. Like if you lose a lot of weight in a short time, the fat patch between the mesenteric artery and duodenum is being lost. They can also go in with that. And otherwise, before going more into detail, I would ask Rabih what ideas he has.
Yeah, Shema, I think you're spot on. I will just say that my personal goal with discussing this case is to try to illustrate the power of analogical reasoning. Because if I were to actually take care of a patient like this in real life, I would go to jail because I don't have a license to take care of this patient and I should go to jail. It would be very flawed. I don't have the knowledge or expertise to actually provide care to this patient. So what this exercise will do is to illustrate how cognitive structures that apply to the patients that I take care of, older adults, are overlay a lot with any human being and even any creature, honestly, any mammal, but there will be significant differences just based on the patient's age. And that's the ultimate goal. So to see how much overlap there is if the age was 30 and to see how different it is because the age is 10. And I think I only have one piece of advice, which is the poor weight gain is definitely the landscape to study here. Why is this patient not gaining as much weight? And in adults, since their weight is already established, the real schema that we're applying here is weight loss. And we're going to borrow from weight loss in adults to help us figure out why this child is not gaining as expected weight. So that's the simplistic model that I would take. And you heard Shema's fantastic approach to that. Now, this is the part that I think everybody should be paying attention to. This is the part which is probably a cognitive trap. Here, the words poor appetite may be equated with a GI syndrome suggesting of malabsorption. However, any systemic issue in an older adult is often causing suppression of appetite. The patients with cancer who lose weight often do it because of the catabolic issue of cancer, but not infrequently as a result of the suppression of appetite. How do you think about this analogically again? This is basically the same pathophysiology as anemia of chronic disease. Whenever you have a chronic condition, there's a whole slew of hormones that specifically block you from using iron and specifically block you from eating. And so here, unfortunately, the poor appetite does not give specificity to the clinical syndrome, in my opinion. But what is it? What is its value? Its value is increasing the probability that this patient is experiencing a true problem. Because if you had heard this patient's actually not gaining weight, but her appetite is fantastic, she's eating well, you'd be like, wait, hold on. Is that problem of perceived insufficient weight gain, is that real or is that a measurement error? Because it would be so unusual to lose or not gain weight appropriately and still have a normal appetite. In fact, in an adult, if you experience this situation in real life, where a patient is actually having weight loss despite a normal appetite, it limits the differential diagnosis to many very small things, profoundly helpful. So to summarize, the poor appetite here is a marker of the underlying cause, does not confer specificity to the cause, but confers validity to the fact that this is the correct problem to pursue. Alrighty, Bia, tell us more.
So we took a table and see which percentile she was in, and she was at a fifth percentile. So her weight for age was at the fifth percentile. She did not have any diarrhea, any vomiting or fatigue, nor jaundice, and she denied having an increased thirst or urination. She did not have any past medical history, except for some migraine, but she didn't take any drugs for that. And a physical exam was normal. So besides her weight being in the fifth percentile, and the height as well was in her sixth percentile for age, but the remainder of the exam was normal. Do you want me to move on to the labs? Maybe the labs can tell you more. All right, so the hemoglobin was 7.5, the MCV 85, the MCH 30, the MCHC 35. The metabolic panel was for the sodium 140, for potassium 4, chlorine 100, CO2 20, the bun was 95, creatinine was 6, glucose was 100, albumin was 5.
So I have to say, seeing that she is in the fifth percentile, 10 years old, and in the lab she has signs of microcytic anemia that really changes the differential, lets me think more of a process within the duodenum. So we could basically think of something like celiac disease. It's also, I was going to German, sorry. If you read a textbook, and usually you think of children that are, firstly, they grow very well, and then we're going away, and there's a percentile dot, or we don't gain any weight anymore. And for celiac disease, the thing is, it is also called the chameleon of gastroenterology, because you don't always have to have diarrhea or something like that. There are people that have celiac disease with subclinical manifestations, where people that can present only with skin manifestations or very depressed mood or loss of appetite. So the manifestations are very different. So, and also seeing the anemia that could also fit with the process within the duodenum, because we can't absorb the iron. And so we could, if you, especially when we go for microcytic anemia, I have a differential that is called the tails of microcytic anemia. So you can think of thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, and sideroblastic. The thing with thalassemia is what I learned, what doesn't fit here. For example, what I once read is you would have a very disproportionately low MCV. So you would have if you calculate the Menser index, that would be below 13. So, and also I would expect something like hemolysis or gallstones that don't fit and that doesn't fit into the differential. But otherwise, seeing that a child doesn't gain weight, we have to think broadly into other any other inflammatory bowel diseases. So I know, thinking from the epidemiology for ulcerative colitis or Crohn's disease, she's in my spectrum too young for that. But please correct me if you have seen a child that had a very early manifestation with that. And otherwise, I'm still very open for Rabih's opinion, what he's saying.
My first opinion is this yogurt is delicious. And listening to you and having this yogurt is amazing. Morning experience. Shema, I think I'll get your thoughts on one other thing. I just wanted to echo that and really say that I think even though the MCV is above 80 here, your pretest probability, so technically it's normocytic, but your pretest probability of a GI disease is centered around the fact that this person's not eating well. And even if the MCV is a little bit above 80, I think you are highlighting the point that the MCV stands for mean corpuscular volume. So patients can have microcytic causes in parallel with normal or macrocytic causes pushing their MCV higher. So I don't think you can exonerate the GI tract simply because there's no, the MCV is not normal. I think for me, the question that I'm trying to understand for this patient is, what is this problem, which we're going to figure out in a moment, but really when has this problem been going on for? And I think the key question to study is, how long has she been at the 5th percentile? Was she born and stayed at the 5th percentile, or did she fall off the growth curve? So that is an open question that will help us solve the problem. But I think, Shema, it's amazing just to pause and reflect for a second, because I know you long enough to ask you this question publicly. If I recently did an RLR that you may not have listened to about 2 months ago, where I had a patient come in and he didn't have pulses in his legs. And so I was working him up for pulselessness in his legs. And I completely missed the fact that he had 3+ lower extremity edema. I didn't see it. So I want for people to learn from your experience, because it seems like you didn't see the creatinine that's high. Why do you think your mind didn't see it? What was it about the circumstances that you're in? Because, by the way, Shema, this happens all the time. It's nothing unique that just happened. It'll happen to you when you're in attending. It'll happen to you. Even surgeons forget sponges in people. It happens. So why do you think your mind was in the situation that it was in to not see that creatinine? And what can we learn from it?
Especially the symptoms, like when I see someone presenting with that high creatinine, I would have expected any kind of edema or that way have something like oliguria. And now I was reading now again and seeing that your creatinine is 6. I was like, oh my God, I missed such a big detail.
Yeah. If I were to guess why it happened, it's actually a very helpful clinical reasoning phenomenon, the pretest probability. The pretest probability has to influence how you are interpreting the subsequent data. And occasionally, it'll influence you so much that you will miss spotting data you didn't expect to see. And this is why when things are not going right, the first step is to revisit the data that you already had. If you're having a problem solving a diagnostic issue, the first step is go back, make sure you didn't miss any data. And now I think the problem here is, what is the cause of kidney disease in this patient? We don't know if it's acute or chronic. but I will try to make the case that it's chronic and then ask you, Shema, to share your thoughts on what that might be. So why is the case chronic? I'll tell you that I think you already answered that question, Shema. The fact that the pretest probability of kidney disease, acute kidney disease, was so low. If a creatinine completely surprises you, as it did in this case for both of us, it's probably chronic. Most patients who have acute kidney injury have it in the context of a predictable reason. They started a new medication, they have diarrhea, they have heart failure. There's always a systemic context for acute kidney injury. A creatinine out of the blue is often chronic. And then when you layer it in with the presence of an anemia without any alternate explanation, anemia of chronic kidney disease comes to mind. So I think that we're probably dealing with CKD. The thing that would be very, very helpful is to see when she has been on the 5th percentile, but not having access to that data will help us get stronger clinically to try to make progress without that. So I'm curious what you think now that we think this is CKD, what diagnoses are crossing your mind?
So especially thinking of pediatric nephrology, what I was thinking, especially also with the anemia, there is something also very typical for female children, something like vesicoureteral reflux, so that they can be very asymptomatic and later on present with anemia and so on. I was also thinking of these cystic kidney diseases like nephronopathies that can go in with several symptoms. I remember this kind of Joubert syndrome where it can present with like cerebellar ataxia. And as you said, medications and also hereditary issues like thin basement syndrome or Alport syndrome, or that can present rather with some chronic kidney disease. That's more of the spectrum, and also I think any kind of obstruction or malformation, sometimes there are some ureteral malformations like ureter fistulus, ureter duplex. So yeah, that's what's going on for me. And we were also discussing some renal tubular issues, so first of all, seeing that we don't see any lack of, I don't know, phosphorus or other electrolytes at the moment. That's not in my differential right now here. Yeah.
Yeah, I completely agree with you. I think when you say it's CKD, you know there's either a glomerular problem, a tubular interstitial problem, or a vascular problem. And in kids, tubular interstitial diseases are much more common, be it cystic tubular interstitial diseases like ADPKD, or the consequences of ureteral hypertension on the interstitium. One of the most common causes under VUR, I think, is now increasingly put under a bigger term called CACUT, C-A-K-U-T, congenital anomalies of the kidney and the urinary tract. And it captures many anatomical issues like vesiculoureteral reflux or VUR, ureteral agenesis, single kidney, so on and so forth. So in addition to the usual workup we would do in an adult, including a urinalysis, a urine to protein creatinine ratio, urine electrolytes, the most important test in this kid, in addition to that, is anatomical imaging of the urinary tract, usually with ultrasound. That will be very, very important. I'll tell you that the lack of hypertension, the lack of edema, and the subtle progressive nature of this has me much more worried about a post-renal cause going into the kidneys rather than an intrinsic renal cause, which I would have expected to result in glomerular hypertension by now. All right, Bia, tell us more, please.
I'm impressed by your clinical reasoning, guys, and just want to know that you already have the answer somewhere in what you said. But I wanted to answer to a few questions of yours. So she was having this poor weight gain for a few years now, but in the previous years, she was in between the 10th and the 20th percentile, so still very low, but not until these days she was in the 5th percentile. And we did urine analysis, and the specific gravity was 1. There were some protein traces, some blood traces, but there were no casts. And we didn't do any ultrasound, but we directly did some renal biopsy. Do you want me to share this aliquot? Because this one is going to give you the final answer. So we found some tubular interstitial damage with diffuse chronic interstitial inflammation and fibrosis. The damage to the glomerulus was minimal instead. And if you want, I can say more about what we thought with this kidney biopsy and what we did. Do you want me to?
Yeah, maybe Shema, I'm curious what you think. Thank you, Bia. I think maybe I'll get Shema's reflexes. This is definitely above my pay grade to think about tubular interstitial disease in children. I'm curious, Shema, what can you teach me?
Wow, I can say I can't teach you nothing about it. It's out of my spectrum. So, but seeing before I go to the biopsy, so we have seen that there are no casts, so that actually explained that we are not dealing with more. So when I think of cast, I would have expected more a glomerular disease, but now seeing that there's a tubular interstitial process, I have to say it's out of my mid-year. I'm really out. So I would now think of any interstitial kidney disease, but I have to say I don't know what causes it. So I don't know whether you did some other renal imaging, like I don't know, ultrasound, because I have to say if I said something now, I would ramble too much. Yeah.
Oh no, I think this you can never be accused of rambling too much. I think if you were to think about interstitial damage in older adults, it tends to be a lot of medications and toxins. So you have heard of the possibility of analgesic nephropathy, for example, and many other medications and toxins like PPIs can do it too. It's also not uncommon in adults to have crystalline disease deposit in the interstitium. So for patients who have chronic crystal issues like gout, like nephrocalcinosis, so a lot of calcium deposition in the crystals. It's also not uncommon for toxins to do it, unfortunately, like heavy metals. Genetic diseases feature prominently in the interstitium, with sickle cell disease being a really important category, as well as the cystic diseases that you mentioned, and many other genetic conditions. Yeah. So yeah, I'm really curious if this turns out to be a primary interstitial disease, medications, toxins, crystals, genetic. It's very rarely autoimmune, but in an adult, you have to think about Sjogren's as a prominent cause, and as well as IgG4 disease. But the thing to know is that in adults, at least, interstitial disease not infrequently reflects chronic obstructive disease. And so the way that BPH, for example, causes chronic kidney disease, meaning that even if you fix the obstruction, the patient still has kidney disease, is through its effects on the interstitium. So that's important to know. But I'm really curious where this case goes, Bia.
Yeah, so our patient was anemic, but with a normocytic normochromic anemia. And elevated bone and creatinine was consistent with chronic renal failure. Her urine analysis was relatively normal, but it was the kidney biopsy that led us to believe that her tubular interstitial damage was disproportionate to the glomerular damage, suggesting a nephronophthisis as a cause, which Sima mentioned. And so for the anemia, did a transfusion of red blood cells, and she was started on erythropoietin. And then she was scheduled for an early visit with the nephrology team for further management. Personally, I learned a lot about nephronophthisis being a autosomal recessive disease, and of course, this has led to the impaired urinary concentration in this patient. So with a progressive tubular interstitial nephropathy and a chronic renal failure.
Oh my God, Bia, I have never, ever heard of this diagnosis, and I'm so glad to have the opportunity to learn about it today.
I mean, I wanted to talk about this because the way I studied nephrology in med school is very similar to learning a list of things. So genetic diseases that you're going to forget the very next day. But with this patient, somehow I got the picture of her nephronophthisis, and I don't think I'll forget about this in the next few months or hopefully years. Yeah.
So were you able to, because of your learning, were you able to suspect this even before you got the answer?
Well, probably it was somewhere in my brain.
Yeah, that's amazing.
But not consciously, I have to be honest.
Yeah. How did it feel though to have your subconscious thought be validated? How was that as a feeling? It's so rare that
it wasn't there. I was never able to get the conscious out of the.
I see. Yeah.
I wasn't that good as a CMA was.
Oh yeah. I think that we're all growing every day, you know, and I think the next time you see this, you will almost certainly recognize it. Shema, how did you pick this up? What was the clue for you?
So basically, I remember from one pediatric nephrology rotation, the doctor was asking us, what is the most common cause for chronic kidney disease in children? And we all didn't know the answer. And then she told us, think of nephronopathies, think of Kakut, as you mentioned. And there was another one, but I don't remember at all. And I'm so happy to see that I got to discuss a nephronopathies case. Thank you so much.
Bia has brought a gift to you. I hope you can share it with that professor who allowed you to get it today. And I think that's the value of we're learning. We're also harsh on ourselves when we don't know something, but those moments are like, if you go back to that moment, Shema, you never knew in that moment that this moment would come, but here it is. And I think that's true for every moment where you don't know something, as I guarantee you, if you put yourself in places of growth and opportunity, you'll go back to remember all those moments and they'll come in handy. So I think you're living that CP solver's dream today, Shema. That's so cool. For me, I have one retrospective reflection that is a growth for me, which is, when you mentioned the specific gravity of 1, I think that was a very powerful clue that the biopsy was going to show some tubular interstitial disease, because the fact that the patient could not concentrate her urine at all, a specific gravity of exactly 1, means her urine must be so dilute, which in the face of such advanced kidney disease has tremendous localizing value to the distal part of the tubules where ADH works, suggesting interstitial disease. So there's no way with my knowledge that I would have been able to guess the answer, but I will push myself next time to at least predict the tubular interstitial disease. And maybe if I were by myself in real life, just Google tubular interstitial disease, young child, and maybe that would have helped me get closer, but I no chance would have gotten it right. So I'm really glad you brought this case. It was really good learning. How do you know, Bia, how do you treat this? So what happened to the patient with all the treatments, the EPO and everything? What's the prognosis? Dialysis, or is there a chance of recovery, or what happens to these patients?
I posed these questions and then I took some notes because I didn't know about this, but apparently the treatment is supportive at the very beginning, but it may include a renal transplant if the patient progresses to ESRD. That was it. The thing is that in this patient, we didn't really have some symptoms like nausea or fatigue, something that might have suggested that immediately that she was having a chronic renal failure. And she didn't even have some extrarenal features like liver fibrosis or bony defects. So yeah, this was what I wrote down.
That's awesome. Thank you so much for that wisdom. It was really, really cool case, and excited to reflect more on this. And Shema, kudos to you. I told you Shema's going to bring the heat, and I think there you go. The heat was brought. Thank you, Shema.
She did.
She really, really did. And really, really excited. We're having Bettina do the teaching points. She's kind enough to stay up super late in the Philippines. So thank you for what looks like really, really well laid out teaching points. Excited to get re-exposed to learning from this case, and take it away, my friend.
Thank you, Rabih, and thank you, Shema, and thank you, Bea. That was a really interesting case. I haven't seen anyone with nephropnephrosis before, so this is very exciting for me. So, first we talked about poor weight gain. So we wanted to look into if there's any systemic disease ongoing that could be related to malabsorption. So when we look into patients, especially children with poor weight gain, we can check for genetic diseases. We look into the birth history. Were they born with any congenital defects, or did they present early on? Is this chronic already, or did the child just have a poor weight gain acutely? So we also ask why the patient is not gaining weight, and we can also revisit the schema we had in CPS before for poor weight gain, which could include differentials that could be delineated by increased inflammation or decreased inflammation, and that could include differentials like cancer, autoimmune infections, malabsorption, endocrine diseases, other chronic diseases, intake of different medications, or decreased intake in our patient. And then we also talked about poor appetite, which could suggest a GI cause, but it can also be any systemic issue which can manifest with poor appetite. So it does not really tell us which specific disease it could be, but at least it gives us a clue that there's a real problem in our patient. So we also talked about celiac disease. Shema mentioned that it is called the chameleon of gastroenterology because it doesn't always present with diarrhea, steatorrhea, and all that. Patients can also just present with skin manifestations. Patients can also have depressed mood and just loss of appetite. So that's something that we considered in our patient as well early on. And then we also talked about microcytic anemia. So we have the acronym TAIL. So those are the different causes of microcytic anemia, namely thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning, and sideroblastic anemia. And then Shema also mentioned the Menser index, which could tell us whether it is IDA or if it is thalassemia. And then we also talked about the elevated creatinine that could hint to us that the patient's disease is likely chronic. So the pretest probability of acute causes would be low for this. So when you add in the anemia that's happening in the patient, then anemia of chronic disease can come to mind. Other possible reasons of elevated creatinine, we could think of obstruction, we could think of kakut or congenital anomalies of the kidneys and urinary tracts. We could think if there's a tubulointerstitial problem in our patient, which is more common in children more than glomerular problems or vascular problems. So aside from getting the labs, the electrolytes, urinalysis, visualizing the anatomy will also be important to get to the root of our patient's problem. So looking into the urinalysis, it can hint to a lot of different things. So first, like the presence of glomerular casts, the presence of RBC casts rather can suggest glomerular disease. We could also look into the specific gravity in the urinalysis, which can hint to us that there might be a problem with the concentration of urine, which can point to tubulointerstitial disease as well. So honing into the interstitial diseases of the kidney, it could have a lot of causes. So mostly in adults, it could be from medications like analgesic nephropathy, PPIs. There could also be due to crystalline deposits like gout, nephrocalcinosis, and toxins like heavy metals, and genetic causes like sickle cell disease. And then there are also cystic diseases of the kidney. And then going into our main diagnosis, which is nephronephthisis. So it's actually one of the most common causes of CKD in children. So if we ever encounter a child someday with these considerations, we might think of this differential now. So it is an autosomal disease that can progress to end-stage renal disease, which could eventually necessitate transplant. And it is a chronic tubulointerstitial disease that impairs the concentration of urine. So again, the specific gravity could help us with that fact. And just to cap it off, Rabih mentioned about pretest probability that I think is a very important learning for us, not just in this case, but in any other patient that we encounter. The pretest probability can influence how we interpret the data, but sometimes we do end up missing things because of the framework that we had already before. So our first step when we feel so lost in the case is to always go back to the data of the patient. So that's it.
Sometimes I feel like I have to pinch myself because it was 6:30 in the morning when we started here, and Bia was being so vulnerable and so honest about the struggles that you've been having with even being here, and then dropping such incredible wisdom and so much humility and honesty with this case, and Shema coming back after a long time and crushing this. And then I don't know what just happened. I can't believe that was your first ever teaching points, Bettina. The delivery was absolutely superb. And you can just tell that something really special is coming by the visual layout that you have. And you told the whole story over again in such a concise and summative way. And you changed the order to make it more logical, including moving the final teaching point about pretest probability as a theme at the end, as opposed to when it came up, which was a marker of such skill. And we're very, very thrilled that that was your first one. And hopefully it's the first of many, many. All right, y'all. Thank you. I'll literally have to pinch myself to make sure I wasn't just hallucinating this early in the morning. But thank you all, and hope to see you next time. Bye.